Good evening. Assalamu alaikum. Thank you. First of all, I would like to thank the organizing committee for giving the opportunity to the young surgeons to present over here. So I have no financial disclosure or any conflict of interest. So the technical goal in achieving total knee replacement, in going for total knee replacement, our technical goals are to achieve neutral mechanical alignment and to restore or preserve joint line. And then we have to have balanced ligaments and as well as maintaining or restoring the normal Q angle. So restoring mechanical alignment, our aim is to restore neutral mechanical alignment in order that the forces through the legs pass through the center of the knee joint. So this will allow optimal load sharing through the medial and lateral sides in order to prevent excessive or eccentric wear of the Foley and early failure. So we have to achieve the neutral mechanical axis. So that the line coming from the center of the head of femur and the center of the ankle joint, it should be in the center. So in order to distribute all the forces which are passing through the knee joint. So restoring the joint line height, the knee function is optimized when the joint line height is preserved or restored. So we have to remove the sufficient bone in order to be replaced by the prosthetic component. So ideally, usually this is the fixed distal femoral is 9 mm, so we have to remove 9 mm bone from the distal femur. What happens if the joint lines is elevated? That will cause mid-flexion instability, patellofemoral tracking, and it will be equal to as patella baha. When the lower joint is low, that will cause lack of full extension. So the distal femur cut affects three things. One is mechanical alignment, the second is extension gap, and the third is the joint line height. So for the entry of the intramedullary jig, because usually we are using intramedullary jig for the femur and extramedullary jig for the tibia. So the entry point is 1 centimeter anterior to the origin of the PCL and slightly medial to it, to the mid portion of the intercondylar notch. Valgus cut angle is preoperatively measured, so it's the difference between the anatomical axis and the mechanical axis. So usually it ranges from 5 to 7 degrees. The aim is that distal femoral cut should be perpendicular to the mechanical axis of the lower limb. So extension gap, the tibia and the distal femoral cut should be parallel to form a nice rectangular space. This will result in balanced extension gap. If the gap is trapezoidal, it indicates the soft tissue imbalance that requires adjustment. So femoral component rotation, there are different methods which can determine the femoral component rotation. These are transepicondylar axis, AP axis or white side line, posterior femoral condyles, and the cut surface of the proximal tibia. So all these acts as a reference point for the femoral component rotation. So if the transepicondylar axis is taken as a reference, so we should make a parallel So if we take the transepicondylar axis, so we should make a parallel cut to the transepicondylar axis. If we take AP axis or the white side line, so the cut should be perpendicular to it. So in AP axis, this is the AP axis or the white side line. If we take a posterior condylar, posterior femoral condyles as a referencing point, so we have to do 30-degree external rotation of the jig in order to get the rectangular space. So in this we can see that in hypoplastic lateral femoral condyle, like in valgus knees, in rheumatoid, usually in rheumatoid arthritis, so we should rely on the transepicondylar axis as well as the AP axis, because if you will rely on the posterior condylar reference, this will cause internal rotation of the femoral component. Here we can see that if we tension the ligaments, we can see to the proximal tibia cut surface, which acts as a reference point. So we can see a nicely rectangular space and a flexion gap. So this can be checked by tensioning the ligaments with a lamina spreader, or we can check with a block, spacer block.
Dr. Ahmed, I'm sorry to interrupt. We're running out of time. Do you want to wrap up? Thank you.
Yeah. So McPherson rule is symmetric gap, address tibia, asymmetric gap, address femur. Simple thing is, simple formula, if the extension is tight and flexion is tight, is a symmetric gap, we have to cut more tibia. So if the extension and flexion both are loose, so we have to use a thicker poly. If extension is good, loose in flexion, this is an asymmetric gap, use thicker poly and readdress as tight extension gap. If extension is tight and flexion is good, so again we have to cut more distal femur and we can release posterior capsule as well. So if extension is good and flexion is tight, so we can decrease the femoral component size to downsize the femur. Extension is loose and flexion is good, so we have to decrease the femoral component and use a thicker poly. So the last step is that complete the distal femoral preparation by two chamfer cuts, anterior and posterior, as well as notch cut. So in PCL substituting design, we have to remove the intercondylar box to accommodate the post and cam mechanism. Thank you very much.